Thank you so much. जब मैं बात करता हूँ आपको पता चलेगा कि मैं यहाँ का नहीं हूँ, मैं इंग्लैंड में रहता हूँ, लेकिन मेरी राजस्थान में पैदाइश हुई थी और मेरा दिल है हिंदुस्तानी. So, thank you. I'm going to talk to you today about another global consensus guideline, but this is on the global consensus on the management of hyperglycemic emergencies. These are my disclosures, none of which are relevant to anything I'm going to say today. I'm going to give you some history on the management of diabetic ketoacidosis before we start, so you understand where we're coming from. So as we all know, diabetes, type 1 diabetes has been universally fatal, or was universally fatal for millennia. And it took some time. There was a chemist in Germany who identified acetone in the urine in the people who eventually died from what we now know as diabetic ketoacidosis. And in 1870, at the Royal College of Physicians in London, a gentleman described two different kinds of diabetes-related coma. The first one was in thin people who died very quickly, having lost a lot of weight and breathing very deeply. And we will all recognize that as the Kussmaul breathing. And the other kind of diabetic coma was those people who were very big, who gently just faded into a coma and died eventually, and we recognize that as HHS. But he didn't know that at the time, but he described both of those different kinds of coma. It was only after that did Kussmaul describe his characteristic breathing in people that we now know as having DKA. Of course, in 1921 and 1922, the whole world changed and insulin became available. And then there was an argument on how to treat people with DKA. And in the United States, we had Elliot Jocelyn in Boston, who started treating individuals and showing that their mortality went down very significantly and he was saving lives. But he was giving very gentle fluid replacement. And then on the other side of the Atlantic, in London, in the United Kingdom, there was a gentleman called R.D. Lawrence, who himself had developed type 1 diabetes and survived because he developed it literally within a few months of insulin becoming available. But he was giving lots and lots and lots of fluid very aggressively. So there was an argument on how to do things and how to save lives. And then in the 1940s and 50s, different people were reporting how to do things differently. And there was a group that they were dividing between North America and the UK who were publishing the most. And they showed that and they were giving between 500 and 2,000 units every 24 hours. To try and save their life. And depending on the likely prognosis, if this person was going to die within 6 hours, they'd give them 2,000 units. But if they were going to die in 24 hours, they'd give them 500 units. But still, that's a lot of insulin. And then in the British Medical Journal in 1977, 3 papers back to back were published showing that you could use low-dose intravenous insulin to successfully bring down ketones and bring down glucose, and that's why we've moved on to the low-dose intravenous insulin infusion. That was then confirmed by a paper in the New England Journal of Medicine by a chap called Abbas Kitabchi. And then around this time, there was this issue about cerebral edema. How much fluid do you give to somebody, and which fluid, and how fast? Because there was a suggestion that in children, if you gave a lot of normal saline, that they were at risk of developing osmotic demyelination and cerebral edema. In 2001, the American Diabetes Association published their first consensus document on the management of hyperglycemic crises, and then it was updated in 2006 and then in 2009. In 2011, I was involved in the first a guideline published from the UK, which I'll talk to you about in just a moment. And that was different to the American guideline, and I'll show you why in just a second. Moving on into the early part of this century, we had the EMPA-REG published in 2012, and then the case reports and the case series and the dangers of SGLT2 inhibitor-induced DKA started becoming more prominent. I then wrote an editorial in the Lancet, and I'll talk to you about that, saying why the American Diabetes Association guideline was rubbish and needed to be changed, and I used that word truly as rubbish. Then we had the first randomized control trial in the use of fluids in children presenting with DKA. This is 1,000 children, showing that actually it didn't matter which fluids you gave, it didn't matter how fast you gave them, it was an idiosyncratic reaction not related to the amount or the type of fluid given. Reports were coming out that the mortality was very low in developed nations, but in India at the time, the mortality, and I suspect it may still be, certainly the latest data that has been published, is still over 30% mortality if somebody presents with diabetic ketoacidosis. I updated the national guideline in the UK in 2023, and of course the global guideline was published last summer, again, which I'll talk to you about. So I'll just talk to you about how I got involved in this situation. This is a brochure from a rugby match which I was invited to go to. You can see how old it was because it still says Lehman Brothers as the sponsor for this match. And when I was going to this rugby game, a colleague of mine who is an anaesthetist kept on asking me, why do diabetes doctors use normal saline, 0.9% sodium chloride solution to treat DKA? And I said, because that's what we always do. And he said, no, why? So he got me thinking. So I went away and read about why DKA is treated with normal saline. And I wrote an editorial, which was published in the British Medical Journal, saying normal saline should be the fluid resuscitation of choice in people with DKA. And this editorial is the single most, this paper is what has given me the most hate mail from all over the world, usually from anaesthetists saying, I have no idea what I'm talking about. But as a result of this, I got invited to join an organisation called Joint British Diabetes Societies for Inpatient Care, and the writing group for writing the first guideline on the management of DKA. And what I wanted to do when that was published, and it was taken up very quickly all over the United Kingdom and in many parts of the world, but we didn't know whether it actually worked. So what I did is that we did a national survey in 2014, so 3 or 4 years after this was first launched. We surveyed the whole of the UK, and we looked at over 250 cases of DKA to find out whether it worked. And what it showed was there were problems. And using the guideline that I and others had written, that a large proportion of people developed hypoglycemia and hypokalemia. So that's why we changed the guideline at the time to say if your glucose dropped below 250 milligrams per deciliter, you add in dextrose and you reduce the rate of intravenous insulin infusion to 0.05 units per kilo per hour to help prevent the hypokalemia and hyperglycemia. But I want to come back to the ADA. So this is the 2001, 2006 and 2009 documents. And this is what they said. This is how you diagnose DKA, according to the Americans. Now, the first thing I would say is this is rubbish. And the reason it's rubbish is because it says you've got to have a glucose above 250 milligrams per deciliter before you can diagnose DKA. Now, I put it to everybody in the audience, if this was newly diagnosed, if you'd had somebody didn't come in with DKA, you'd use a criteria of 200 milligrams per deciliter. Yes? So why is this going for 250? So I said to the Americans, you're wrong. And you're making, this is a high bar. And then if somebody comes in with a pH of 6.8, but they are completely lucid and completely fine, how do you classify them? Or if somebody comes in with a pH of 7.2, but is unconscious and moribund, how do you classify them? Mild, moderate, or severe? So this is wrong. And they said, oh yes, we agree with you. It's wrong. So this is the UK document that we originally used, and this is how it makes it very easy. You've got to have the D, so glucose above 200. You've got to, or a history of diabetes. You've got to have the K, and you've got to have the A. That's how you diagnose DKA, DKA. It's not difficult, but the Americans don't do ketones. So, that's the problem. The Americans had not insisted on having D. So you have to have a glucose of 250. They had no idea about ketones. They didn't really use ketones because the Americans do not have bedside ketone monitoring. It's a laboratory test. And they use urine ketones, which is useless, essentially, unless you don't have anything else. and you've got to have the A. You've got to show that they've got an acidosis. And so they had lots of problems. And that's why I wrote this editorial in the Lancet Endocrinology saying that they needed to update it. And eventually, they agreed. And so what we did, we started getting together in 2022. It's a consensus guideline between the Americans, the Europeans, the UK, and the ACE and the Diabetes Technology Society. And these are the co-authors. And you may have seen these published on the same day in Diabetologia and Diabetes Care with Guillermo Amperez. If you're into inpatient diabetes, he's the global god of inpatient diabetes as the first author, and I'm the last author on this document. So what we wanted to do is just provide up-to-date guidance, the most up-to-date evidence-based information on how this condition should be managed, and also for everybody managing this condition, right from the front door in the emergency room all the way to discharge from the general wards. And the way the Americans write it, I have to list a series of questions, and these are the questions, and I'm not going to go through all of these for a lack of time, but there's just a few things that I'm going to go through. So, pathophysiology, you'll be glad, has not changed in DKA. I'm not going to go through this in any detail. Essentially, this diagram is freely available to download from the Diabetes Care or the Diabetologia website. It's free. Even the guideline is absolutely free. Essentially, you have low levels of insulin. In DKA, you have so little insulin that you allow ketosis. The ketones form very quickly, so you develop ketoacidosis. In both HHS and in DKA, because of the decreased glucose utilization, you develop hyperglycemia. And with the hyperglycemia, you end up getting an osmotic diuresis. That leads to hypovolemia, decreased renal function, and that leads to problems. And so you have this balance between DKA and HHS. And how does it treat it? Well, again, this is where there's consensus and not consensus. So, of course, fluids, you have to determine the hydration status first of all. If you're somebody who's severely hypovolemic, you give lots of fluid. Mildly hypovolemic, you can decide how much you want to give. And of course, in HHS, if they've got cardiac compromise, you need to get them to an intensive care unit, ideally with a consideration of whether they need cardiac pressors. You give them a certain amount of fluid, depending on their hydration status, and we can say you can either give 0.9% normal saline, or you can give a balanced crystalloid, because there's data to show that balanced crystalloid may improve the outcomes a bit faster because you don't get the hyperchloremic metabolic acidosis that you get with giving lots and lots of normal saline. And then when you reach a glucose of less than 250 milligrams per deciliter, you add in dextrose to act as the substrate for the insulin that you're having to give if they're still ketotic. With insulin, you've got either mild DKA or moderate or severe or HHS. And if you've got mild DKA, you can treat it with subcutaneous insulin, because this is written for low resource environments and high resource environments where you can, if they're paying for their own care, it's cheaper for them to be treated in the emergency room. So you can give, but it's at the same dose. Of course, if you've got moderate or severe DKA, you want to give intravenous insulin. If you give a bolus, it's 0.1 units per kilo, and then followed by an infusion of 0.1 units per kilo per hour. Or if you're giving it subcutaneously, it's again 0.1 units per kilo per hour, or 0.2 units per kilo every 2 hours. And if you've got HHS, you have to give them fluids first. You only give people fluids when their glucose stops dropping. And the reason for that is because if somebody's got fluids going in, their osmolality comes down. If you've got insulin coming down, their osmolality comes down. If you reduce the osmolality too quickly, that then leads to central pontine demyelination. So to stop that from the risk, you give fluids first, only give the insulin when the glucose stops dropping, although some people, certainly in the United States, would give both. And the rate of insulin infusion is a little bit lower, it's 0.05 units per kilo per hour. And then when it starts dropping, and when you get to resolution, you can change things. Now with potassium, you have to ensure they've got adequate renal output, and that's 0.5 mils per kilo per hour. If they've got a potassium which is low, do not give potassium, because the moment you give insulin, it's going to drop it further, increases the risk of cardiac arrhythmias. If it's high, then you can just give the fluids and the insulin, but don't give extra potassium. You want to aim for a potassium between 3 and 5, and then you can start adding the potassium into the replacement fluids. And there's advice on how frequently to check their electrolytes. It says do not use bicarbonate, you don't need to use it unless they've got a very profound renal failure. and you do not need to give phosphate at all, usually. So these are the new diagnostic criteria. This is very different from the old American guideline. It's a glucose above 200, it's a ketone above 3 millimoles per litre or more than 2 pluses in your urine, and it's a bicarbonate of less than 18 and or a pH of less than 7.3. So those are the changes. Just briefly. Severity, we've talked about severity, I'm not going to go into that too much. This is the criteria for resolution, no ketones, pH of greater than 7.3, and glucose less than 200 milligrams per deciliter. Just in the last few seconds, I'll talk about HHS. It's an osmolality above, either calculated or total above 300 or 320, no acidosis, no ketosis. That's how you diagnosed HHS. What's the criteria for resolution? It's an osmolality of less than 300, hypovolemia, so you've got a good renal output, cognitive status which is improved, and a glucose of less than 7.3. There remain lots and lots and lots of unanswered questions in inpatient diabetes. If you are doing any work in inpatient diabetes, feel free to publish it and ask me as a reviewer. I'm going to skip the next few slides, but if anybody is interested, this is the most comprehensive review in DKA that I've ever seen, because I wrote it, and I will leave it there, so I'll say thank you very much for your attention.